Today, we welcome Dr. Tomás León, a psychiatrist dedicated to old age psychiatry and dementia care. Dr. León believes that to reduce the impact of dementia, we need to connect scientific knowledge about dementia prevention to the general population and policymakers in a friendly and simple language. Toward that vision, Tomás works in research in old age mental health and public policies to raise awareness of dementia and their caregivers. His strategy is to work on the implementation of dementia care services and look for a way to make them more cost efficient. He has led several projects to train primary care professionals on dementia, delivered many talks, as you would imagine, and written articles for the general public about dementia. More recently, he's written a book for children about dementia to help them understand the process their relatives could go through and help them cope with it. As you would imagine, Tomás has many positions that he holds. He's currently part of the Directors Board at the International Psychogeriatric Association, and in addition to being a Senior Fellow for Equity in Brain Health of the Global Brain Health Institute. So welcome, Tomás. Thank you for being with us today from Chile.
Thank you. Thank you for the invitation. It's an honor to be here.
So, Tomás, I'm going to just start by taking you back a little way in your life. Career choices are often based on life experiences. So what really prompted you to go into the field of psychogeriatrics?
That's a very interesting question, but because I must say, and this is something that is shared with my colleagues that works in old age, or I mean, a lot of them at least, that I was raised by my grandmas. Okay, but my parents works, of course. We didn't have money for like a daycare, so I was some days with my father, mother, and other days with my maternal grandma. So by doing so, and in that period, I of course received a lot of love from them because I was the first grandson from both sides. And I also realized in that period that my grandma were both of my grandmas were very lonely. Of course, they have their families, but they didn't have like a lot of friends or a lot of activities like suited for them. So I noticed how that impact in their mood, in their well-being, and years go by, and both of them had dementia. We actually had to take care of one of them. And then I realized that also caregivers, care partners, how we should say now, were very lonely in that period, in that task. And it was so hard. I remember that I was a med student when we have to take care of my grandma. Of course, when you're a med student, you feel that you know everything and everything is easy and everybody else is stupid because that's what's made a med student. So I say like, I'm going to take care of this like that. It's going to be very easy. And it was so hard, like so hard. I remember saying like, I don't know, over 2 or 3 weeks, I was so tired and I was hating my grandma because their behavioral issues. So I realized then that, well, this is really hard, and no one teach you how to do it. And no one teach you what this is really happening in the brain or how to deal with that. So I realized that I have to do something about it. Like, people like me, like my mother, need help. So that's when I'm starting in med school, and then when I was in the psychiatry residency, specializing in old age psychiatry. And it's funny because at least in Chile, we don't have like a track for becoming an old age psychiatry. It's pretty much you learn what you can in your med school and in your residency. I remember when I raised that issue to my bosses when I like a young faculty, I said like, why should we teach, especially psychogeriatrician or why we should teach all age mental health? And I was like, well, because there are a lot of them. It's going to be even more in the future. But the feeling that was that from my teachers, that was not necessarily basically because we all know how to deal with them, and they're not gonna be alive much longer. That was like the message, like yeah, we could do something, but what's the deal with them? Because they're like really hard to treat because they have so many diseases and they're gonna be dead soon. And I felt that answer was awful. Like, you can tell me that. First, because they're gonna live like 20 years from the 60s to the 80s, and that's enough time to care for them. But nevertheless, even if they are gonna live like 1 year, there's no reason to treat them badly that year. So I started working and researching in that, and that's the reason that I work in old age mental health, but also that the reason I want more people to work on old age mental health, or train people who are going to work, even if they don't want to, they're going to work with elderly, like primary care physicians or general physicians, until teach them how to do better, how to work better for them and for their relatives.
So, Thomas, it's interesting you talk about this, your real life experiences, but also your inquiry, your curiosity as to why this is not happening, why there's not education. Chile has an interesting history in the field of aging. It's got an impressive number of age-friendly cities and communities, age-friendly environments being one of the action areas of the decade. There's been a positive aging bill in 2020. And of course, the current UN Commissioner for Human Rights is Madame Bachelet. So with this at the backdrop, because I know the former First Lady of Chile was very interested and a great advocate for older people. Can you talk with us a little bit about the status of dementia care services in Chile?
As you may know, Chile is a very long country. Like, we're very thin and we're very long. And people say that is a representation of how different we are. And that difference is also manifested in dementia care systems. Because we have this big capital that is Santiago, the capital of the city. And probably in Santiago, in certain areas of Santiago, we are Norway. I mean, we are perfect in the health system. Everything works fine. The streets are very wide and very, age-friendly. There are daycare centers. There are, I don't know, places for caregivers to have support. But I should say that reach 10% of the population. We have another probably 30–40% of the population that lives in urban areas like Santiago, but in poor neighborhoods. And that is something that a friend of mine told me that is called the post like the post number lotto, like where you live, you get some resources that if you live like in the next street, you don't get them. So in other areas, we have some support, but mainly like general health support. And they try to accommodate their resources, the limited resources, for all age mental health. And I say that probably half of the population, no, 30–40% to be fair, do not have any support because they're either in the rural areas where health system or I don't know, the system, the way the streets are built, are not made for all age. And this is very interesting because I have I mean, I don't go out with my grandma that much because he's in a bed like now, but I have a daughter with a cerebral palsy, so we also have like a wheelchair. And it's funny because when I walk all through Santiago, there are areas that I can walk perfectly, and there are other areas that are forbidden for us because there are no space in the sidewalks, there are no ramps, there are no way to get some areas, and that is something that happened to all age people. So the problem, and why is that happening, is that dementia policies have depended barely on the government in position in that time. And usually what we have, at least I think in Latin America and probably in all the countries, but we have a very extreme cycle of politicians from left to side, from left to right. And for example, what happened with Cecilia Morel, the past first lady, that she was actually very interested and very motive about all age health in general, like how to age in a good way, is that new government, and this is not a political statement, but rather that new government felt that all the past things that the government made are bad because it was made by the last government. So they erased most of them and they start anew. And there is a problem with that because every 4 years you have to start anew. You have new ways to deal with health issues in old age, but also in public policies like in friendly cities, healthy aging. And that has been a major issue. For example, in dementia, we had one of the first pilot in national plans of dementia was very new for Latin America. And then the next government say, no, that's too communist because it was made in a lefty government. So no, that's not going to work for us. And I could understand if they change the policy due to implementation studies and like a thought reflection that said, okay, this is not working because this and that, and we're going to keep the good things about this policy and we're not going to improve them with other things. But the answer cannot be, no, but that's too lefty and that's too righty. So we're not going to do that anymore. So I would say that the position, if you compare us with the rest of Latin America, we're pretty good because there are some areas that are excellent. And in Latin America, we don't get that many health programs, for example, like dementia programs, but we could be very much better. We could be better because we have the resource to be better. Well, said there are some barriers in the government to be better, but there are also barriers in the people who implement those politicians, like doctors, nurses, I don't know, mayors and stuff like that.
You know, you've talked about the importance of education, and in that story you were telling us, the political cycles really impact progress in the evolution of services. I just want you to just unpack a little bit more about that 30 to 40%, that are without services. And, you're really speaking about the social determinants of health, rural and remote people living in those areas. Could you talk a little bit more about, it's a large population, 30 to 40%. So how did they access health services and services for people with dementia? What's their pathway, Thomas?
Yeah, so we here in Chile, we have two health systems. One is the private, that is for the 10 to 20% of the population, that is very expensive, and it's like a highway. Everything is fast. Everything is I mean, you can get an MRI tomorrow if you want to. And 80% of the population is in the public system. And of course, that is not that saying that 80% of the old age people is in that population, because 95% of the population is in the public system because it's expensive. So, for example, if you are in that population and you say, okay, I'm sick, like I have a cold, you have to go to primary care. And primary care say, okay, we can solve that. And if we cannot, we should refer to secondary care or tertiary care. The thing about, for example, dementia is that every person with dementia for primary care is too hard because they don't have training to see dementia. So in 99% of the times, primary care are going to tell you, if you came, for example, with your grandma, with your father, or yourself with dementia, cognitive issues, yeah, we can solve that. So you have to go to secondary care. And that creates a level of overload for secondary care that is unbearable, that secondary care could not solve all patients with dementia under caregivers. So the waiting list, like, for example, I go to primary care now, so now I have dementia. Okay, we're going to put you in the list to see a neurologist. That could be up to 3 years. Of course, as I said, in some neighborhood, that is 2 weeks or a month. I think that's okay, but it could be 2 years. And if you see a neurologist for the first time, after waiting for 3 years, you say like, yeah, but I need a CT scan because I'm not sure what you have. That CT scan is going to be ready in 6 to 8 months. And then you have to wait, and you're back in the line. You're back in the last position in the line. So what has generated is that either people with dementia and their relatives spend a lot of money to go to private care, to have somebody take a CT in 2 weeks and tell them what they have, or they don't have a diagnosis or if they have a diagnosis, they are not treated correctly because they are given, I don't know, high peripotent sedatives like benzodiazepines and sleep pills, and they don't have the support to that. And the problem is that contrary to that reality, the public policy that we have now says that okay, no, we have a lot of people with dementia, so 80% of the people with dementia should be seen in primary care, because they're saying like the classical Alzheimer's disease as not complicated people with behavior like could be solved with low doses of medication and not pharmacological issues, treatment, sorry. The thing about that is that, and this is very funny in Chile, that we first create a law, an instruction to primary care, and several years later, we explain them how to do that. For example, we have this new law after the National Plan of Dementia is something called the AUGE. That is acronym for the guarantees in health. So if you have dementia, you have certain guarantees. You have a guarantee to, for example, medical appointments or psychological appointments or medications. But after 3 years, 4 years now of having that law that say, no, if you have dementia, you should go to primary care and you're guaranteed to have some medication and interventions, we still don't have the guidelines for primary care physicians or professionals on, okay, but what do I give them? Like what medication, like, and what doses, in what cases I should refer them to secondary cares, and what cases I shouldn't have. And that is very hard. I mean, scientific societies, we have worked on that guidelines from, I don't know, 5 years from now. And we're telling the minister, like, okay, you have to give them a guideline, because the guy in primary care doesn't know about it. It's not that they don't do that because they're bad people or they don't care about dementia. They just don't know. They don't have the training for that. You can pass 4 years without telling them what to do, because what happened now is that all the people go and say, I have the guarantee to be seen. But there is a trick, because in the guarantee said, if the patient is too hard for you, you can refer to secondary care. Just if the patient is too hard. Yeah. But if you don't have the training, everything is too hard. I mean, yeah. Fracture that I see is too hard for me because I have no idea how to deal with a fracture. So I will refer everybody.
Yeah, you know, it's really, you've described a very complicated political cycle that can go from left to right very quickly, that erases the good work that's been done, but also very complicated pathways and a lack of education and then implementation of guidelines. I'm going to turn to Valerie Powell and Dominic Boyd, Thomas, they're going to come forward and ask you a question. So Valerie?
I worked in psychogeriatrics for over 20 years, and there are wonderful examples all over the world, isolated examples of care that work. There are programs that work. There are other levels of care other than medical practitioners, even down to the front lines, who, once there's a diagnosis, often it's just the care and the management of behaviors that's important. We know all this, but there isn't the political will to address it, and there isn't the funding provided to be able to actually implement a lot of the models of care that we know work. So it's a little frustrating.
So it's really a comment that reinforces what Thomas was really saying, that you know, the frustration is not about that we can't serve these people, but we just don't have the funding and sustainability of the programs.
Yeah, and also complementing what Valerie said, that at least here there's an idea, a wrong idea in my opinion, that dementia care should be led by doctors, medical doctors, and should be led especially from high super specialists, very like top 8 researcher doctors. And I think that's wrong. For once, because there are not that many like neuropsychiatrists with PhDs in dementia care in the world to deal with all the people with dementia, less in Chile. But second is that we doctors, we know a part, and we barely know a part of what is need to be done with people with dementia. And there are wonderful not medical professionals that could help us and teach us a lot. I'm talking about nurses, psychologists, occupational therapists, physical therapists, speech therapists. So, for example, in this program that is the HES, what was guaranteed was the medication, donepezil and memantine. And say like, oh, but we're getting a lot of donepezil for everybody. And we say like, yeah, but yeah, that's not really the issue here. I mean, donepezil was expensive, and now it's cheaper. That's good, but that's not a silver bullet for dementia at all. Even if we have like lecanemab, that's not a silver bullet either. So we have to raise knowledge and raise strength in non-medical teams to deal with dementia. And in that, I think that we doctors should take a step aside, a step back, and let other people lead these interventions, because they're that much better than us. Nurses are much better than us in care, like in long-term care. Occupational therapists are much better than us in dealing with behavioral issues. But I think that there's a power struggle, you know, because if you say like, no, there's just going to be a roundtable in the ministry about how to deal with dementia, they're going to invite doctors, just doctors, and I don't think that's right. We should invite everybody, doctors, of course, but also non-medical professional and people probably with dementia, and social organization that could also tell us how is to live with dementia, what is important when you're living with dementia, not just if we are going to buy more donepezil or more, I don't know, lecanemab or aducanumab or whatever.
Look, thank you for that, Thomas. And also caregivers, you know, are part of that round table. Dominic Boyd, you've got a great question. Dominic?
Thank you, Jane. Appreciate what you're saying, Dr. León. And my concern revolves around looking at things from a macro perspective here. You mentioned about the switching of power from one party to one side to the other on a sort of a regular basis, and how that upsets the apple carts. And so it is good that you're noticing that, obviously. Are there particular sort of bodies that do represent seniors in some way in Chile, which are able to critique these issues and hopefully exert some influence for the better? there. Here in Canada, we have you know, a variety of seniors groups. We have on a national basis the Canadian Association of Retired Persons, for example. Here in Nova Scotia, we have aging well coalitions around the province, and so seniors advocacy is a big piece of what we do in these groups. So I'd be interested to know what's happening in Chile related to these advocacy issues.
We have one. I mean we have many, but I think one is the bigger one that is called the cane revolution, la revolución de los bastones, like the cane, like to walk, the revolution. And it's great. It's great. There's a group of elderlies that have organized and start demanding people to politicians, and they used a very interesting epidemiological data. They say, listen, like politicians, you are creating all your laws for people in their 20s, but if you see who votes, we vote. People over 50 and 60 are the ones who votes the more. So we are the ones that you should attract with your laws and your proposals, not the 20 years old, because they don't vote. And they have generated some changes. I think they were very connected with the last government, as you said, Jane, with Cecilia, the past prime minister, sorry, the past first lady. And I have talked with the leader and a wonderful lady, and they told me that most of the government they promised them more funding and like transitory changes, and they say like, okay, one of the phrases was like, okay, but make it a law. If you make it a law, the next government cannot change that. And she was like the first one to teach me that, like, okay, if you want changes, for example, in how much money they or elderly gets, or how much benefit they get from for the transport, we make it a law. For example, one law that they managed to get was that our senior citizens pay half of the price in public transport, and that's a law that cannot be changed. I mean, can be changed, but it's very hard to change. And that's something that they manage, because they say they went to the government and they make like huge manifestation and stuff like that, and said, we earn, I don't know, $100 a month, and we cannot pay 10% of that in public transportation. And they're now a little quiet because I haven't heard of them in a while, but I think that's the bigger example of how they can organize and change that. In caregivers, they're not that organized. I mean, there's some caregivers institution, but they're mainly for providing help for other caregivers. You know, like I don't know, group therapy and support between the like a network. They're not that well organized to do pressure in politics, but there are some social organization I think I'm thinking about too, that they have collection of professionals, caregivers, and patients, and we have I'm part of one, and we have tried to impact in policy, and to do that, and this is very interesting. To do that, we have like a star, you know. We have the case of a very known TV director that has Alzheimer's, and now he has severe Alzheimer, but he's married to a very known actress here in Chile. So since they were famous, there was more you know, there was more like TV time to talk about dementia, to talk about Alzheimer. And there's actually a movie that I recommend you to see, because it's going to be in a while, won the Sunrise Award, about their story. It's something called like the history of a memory or something like that, but it's their story of love and how can love sustain dementia. And they have been very active in putting that Alzheimer's and dementia in the public discussion. And I think that we are doing something with that. It's slow, it's very slow, but we are doing something about that.
Look, and I think that's a real life example, isn't it, Thomas, of people sharing their story about the impact of dementia, but also how people with dementia, can live, a full life also, with various supports and care systems. Thomas, every single week we have an attendee at our Global Cafe, and his name is Shmuel. So I'm going to share his question with you today. What are your recommendations for improvement of mental health of older people from poor and low socioeconomic groups of the population? What are your recommendations?
Yeah, that's, I mean, that's an easy and a hard question at the same time, because of course there are common recommendations. Let's say do exercise, go outside more, interact with others. But of course, when you're like from a poor social position or living in a poor country, in a poor area, that is very hard. There is a joke like in social health that say like, what should I do to diminish my risk of X? Don't be poor. Don't like, yeah, but that's not really under my but that's probably one of the biggest thing that you could do to not be poor. But I should do that. I should say, sorry, that mental health is like a big bag of things, it's not just mental diseases like depression or anxiety, but rather a big spectrum of well-being. And of course, there are some things that are associated, and then we have very good reference to say that they're associated with better mental health, like exercise, social networks, good interaction with their families, and probably an adequate way to feed yourself, like, with a healthy food. What I will say that, as I said, is harder to do in a hard, or when you're poor, or where it is hard, you get money and you have to work 24/7. And of course, that is the born of the social determination of health. But what I should say that, don't aim big, but rather aim small. Like if you take the list of everything you should do to be well in your mental health, that's overwhelming. Because they're like, you need like 30 hours to do like 1 hour of cardio, 1 hour of reading, 1 hour of meditation, 1 hour with your kids, 1 hour of work, etc. So what I tell my patients is like, okay, here's a list, and you can download the list everywhere, but do not do all the list, but rather focus on what you can do, even if they're small. Like if you put 10 minutes, and probably 10 minutes is easier than an hour, of physical exercise, of meditation, of social connections with a relative, that is something. I mean, you make it the first step, and that first step is going to help you take the next steps, because if you want to do everything at once, it's going to be everywhere, and you're going to get frustrated, and your mental health is going to be worse, and you're just going to be thinking that this is unreachable and this is impossible to get. And only rich people can get really good mental health because they can afford being meditated in 2 hours in I don't know, in the Himalayas. So that's what I would say. Like do the classicals, but it's don't aim high, aim small, and then you can reach high.
I think what you really shared is, messages for everyone on this call, because I think we are all overwhelmed with the opportunities to do exercise and meditation and reading, but where do we fit it in? So starting small is a good message for me too. Look, Thomas, I really want to talk with you about the reasons that you wrote a book for children, because we often talk about the importance of intergenerational learning, and we know from the World Report on Ageism that cross-generational approaches to combat ageism is so important. So why did you write this book?
Well, this is a book, as you say, about dementia. There are like 4 short stories, one for each of the main causes of dementia, one for Alzheimer, from Lewy, from frontotemporal dementia and vascular dementia. And they're short stories about the child point of view, like if they have a grandma or a grandpa with dementia, how they change, and how, for me as a child, it's unexplicable why they change, and why my grandma is now telling me another name, why, for example, my grandpa is not answering my is apathic, you know, is not answering my calls or my jokes anymore, why he's now a changed man if they have frontotemporal dementia. So the idea to create that was, it was first like a personal story about my experience with my grandma with dementia, because when she died, my grandma was a very special person, so she didn't want to be taken care of, so she lived in their house until the last time. So when she finally died, we went to their house and we saw that she had so many like post-it with the name of their grandchildren, or they say like, okay, today is Monday, or my daughter are X and X, my grandchildren. And so I said like, how she struggled to deal with dementia. And it was so hard for me to understand them. So I said, if I were a child, this could be very hard to understand. Why she's writing my name over and over. So I wrote the first one about Alzheimer, and then I realized that, hey, this could be a good asset for people who to understand our dementia. So I created them, the other 3. Of course, I'm not a writer, and they're probably very bad in the grammatical and poetic way, and we're working with an editor to help me with that. But when I had them done, I said like, okay, what do I do now? Like, this is an issue with me. I like, okay, I have this idea, and I couldn't sleep with it. What do I do now? How do I get this idea to more people? So I contacted a lot of people, and this is something that you learn to do. Like, you learn to networking. Like, I send like a 10 to 20 emails, like, hey, I have this idea. And of course, most of the people say like, okay, good luck. But there are 2 to 3 people that say like, oh, this is a great idea. Let me, something resonate with them and say like, yeah, this is a good idea. So we start getting in funds, and we finally got some funds to do that. And as we speak, the illustrator is working in the illustration, and the editor is working in the writing, and we hope to get that book published probably this first semester. And the thing about it is that, okay, well, I say, okay, but I don't want to distribute them with doctors, because doctors know about Alzheimer's, or at least I hope they do. So we contact with the Ministry of Education, and I say, okay, I have these books. I'll cover the pay. I'll cover the printing. I want to give them to you for free, but you have to give them to kids in the schools. And they say, okay, that's great. Because what I have learned is that if you go to the government with a problem, they don't listen. But if you go with a solution, they do, especially if there's a free solution. Like, okay, you have a problem. You start with like this. Okay, you have a problem because you have a lot of kids. They don't have any idea about dementia, and they will have grandpas and grandmas with dementia. But I also have the solution. Okay, this is the solution. You just implement them. You just give them to the kids. And that was so easy. And the minister was like, yeah, of course. Yes, just lend me the books, and I will give them to children. So that's the idea. That the idea is to connect with the kids and say, okay, this is dementia. Because when we, for example, in our clinic, when we give the diagnosis of dementia, we always tell them, of course, to the patient and to the caregivers, but we only tell caregivers over 18, so over 18, because we are, I don't know, we are an adult-centered society, so we thought that the kids are stupid, and they're not. But we only get adults the recommendation and the instruction, but we forget that there are children living in the house most of the time. So we are relying that the adult that we told about dementia is going to tell the children about what's happening, and that's not always perfect. You know, that's not all. The communication is not always what we want them to know, and we have realized that children interact a lot of the time and a lot of ways with people with dementia. So we have to teach them.
Yeah, look, that story is inspiring on so many different levels, Thomas. You know, the idea of just sending an idea out, and you're quite right. You know, I love the people that go, yeah, great idea, good luck.
Yeah.
But there's always one or two people, and you know, I hear it every day. Oh, good idea, good luck. there's always one or two people that go, yeah, look, I think we can do something together. And those are the people that you need alongside of you. I think the other thing that you're so real in your stories. You know, it's about government wanting solutions and a free solution. And more often than not, if you offer them their free solution, then they'll certainly badge it that their idea, which is great, I don't care, but they'll go with it. So your stories are very real. We have one last question before we start wrapping up, and it's a comment and it's a question from Denise Zhuang, who's at the University of Hull in the United Kingdom. Denise, would you like to talk with Thomas this morning?
Well, I'm Canadian, I'm in Canada, but I study online, but
Okay.
It's a really interesting program, and it actually is made up of people from all different industries. We have social workers, doctors, nurses, pharmacists, optometrists, care workers. So we have a very collaborative discussion on solutions when it comes to dementia. And one of the things that came up was about personality test or aptitude test, because we've come across this in every field, professional and non-professional, that if you don't have the right personal qualities to approach dementia in a dignified, respectful way with an appreciation of human rights, then no matter how intelligent you are, you could be the best doctor in the world. But if you don't have that ability to understand the personal relationship to dementia, then there's something missing. So what do you think about that, I guess, is my question. Like, do you think it's possible that we could start to divert in training or universities, that we were looking for certain types of people? I mean, there are probably a lot of people that had those personal skills already, and they just haven't thought, oh, I would be very suitable for this work.
Yeah, I have two opinions about that. One is that we should do that, and the other that is that we should not do that. And I will explain both. I think we should do that because, as you said, dealing with care of people with dementia and their caregivers is hard. And you need a way to approach them that is different than the way you approach everybody. And that not only includes knowledge, and probably it's not that the bigger deal, but rather attitudes, way to deal, to express yourself, and way to interact with others. So of course we should look into that, and we could, as you said, like give you like a note. Say, this professional is like has attitudes through dementia. And we could also do that, not just with professionals and people in healthcare, but we could do that with everybody. Like, for example, there is an example of in Ireland where my professor, Brian Lawler, go to the banks and say, this bank is dementia friendly, you know, because their cashiers are trained in what dementia, and they're not going to be bored if the guy takes 10 minutes to find the checks or write, I don't know, remember the password or whatever. And that was very interesting because it was, of course, friendly to the society, but also it was good for the bank because now all the people with dementia, or the sons of the people with dementia, transferred their accounts to that bank because that was dementia friendly. And you could do that with everything, with box store, with I don't know, supermarkets or whatever. So we definitely should do that. My issue is that there's some areas here in Chile, in rural areas, there's one doctor for the whole area. So what's happening is that doctor, it's a son of a bitch. It's a very bad person. I hate dementia, I hate old people, but he's the one. He's the guy who's there. Not having their badge of dementia friendly. What you do, like if you are in that area, should I move from that area? So that could create a discrimination for people who are unable to access other areas with other doctors. And we have areas with there's one doctor, the one guy. So that's the guy. I mean, that's the guy you get. So that's the issue I see with that. I think that we should aim to have these attitudes probably in most professionals. And we say like, okay, even if you're just the one doctor and you want to be a radiologist, you're going to deal with old people. Sorry, but that's the way society is. You're going to deal with them. So you have to learn about this. I'm sorry. I'm going to be a psychiatrist all my life, and I had to learn how to do a C-section for pregnancy. I had to, because I was going to be a doctor one day, and so I had to. So we should include these soft skills, in something that everybody should learn, because everybody's going to live with them, even if you don't want to.
So, Thomas, one last question before we wrap up and I introduce the next week's expert speaker. So just last year, you, like myself, were identified as one of the Healthy Aging 50, in the launch of the UN Decade of Healthy Aging and also the WHO Collaborative. So going into the future, what will be the status of mental health in Chile in 5 years? What would you hope that Chile has achieved for people with dementia and also older people and their mental well-being?
That's hard. That's hard because there's one thing that I will want to be here in Chile in 5 years. And another thing, what I really think that is going to happen. I will start with the positive. I will hope that in 5 years, what we could do is that we realize that old age mental health is an issue for everybody, and we realize that it's not going to go anywhere. So we have to tackle that, and we hope to have everybody. And when I mean everybody, I mean professional, but also the society. I want to say more trained in mental health, but be realistic. Just knowing that is something that exists is going to be a huge improvement, because there is an idea that if the old lady is depressed, it's because she's an old lady. If she has memory issues, it's because she's an old lady. If she feel lonely or whatever, it's normal, because it's the way it is. Old age is sad, so it's normal if you're sad. If we manage, and we're working with that, if we manage to just introduce, the idea of, yeah, maybe that's not really normal. It's not normal to want to die every day. It's not normal to feel lonely every day. I mean, all day. I think we have won. I mean, we have created one small change. What I think is going to happen, because currently I don't see that many political interest in old age, and they have told us that. I mean, when we went to the minister with our dementia plans, they said dementia is not a priority, and by saying that, they also said old age is not a priority. Young people are the priority, and that is good. I mean, they should be a priority, but mean, we all should be a priority. But so what I think is going to happen is that there are going to be, and I hope there are going to be several like individual proposals to improve old age mental health. And I think our challenge is going to be to gather all that individual proposals and ideas, and as you say, make us strong to negotiate, to deal with and to talk with the government, say like, okay, this is all we are already doing without your help. So let's help us to do even more.
Look, I agree with you. It's about bringing different sectors and disciplines to the table with their ideas to develop a common agenda, to be a powerful influence. So, Thomas, I'm going to leave you there for just a minute while I introduce next week's cafe, and then I'm going to come back to you, and I'm going to ask you to give, a couple of takeaway messages to our attendees today. It's going to be a great pleasure next week because we're going to hear from Dr. Margaret or Dr. Kathy Pecora Fuller, Professor Emeritus in Psychology at the University of Toronto. We're moving into, Hearing Week. And so I've got that title wrong, by the way, but it's about hearing, and it's about the week, and it's about focus on hearing and hearing in later life for us. So Kathy's going to be talking with us about making ear and hearing care a reality for older adults. And in many parts of the world, older people do not even have access to free screening. And to quote something that Thomas just said, the notion that, your hearing deteriorates as a result of age is actually a myth. So please join with us next week to listen to Kathy Pecora Fuller, Making Ear and Hearing Care a Reality for Older Adults. And I just want to thank my colleague Roxana Badiai, because she will be moderating next week. For the next couple of weeks, Greg and I will be in Australia experiencing 38 degrees heat and not minus 23 degrees. And we'll be back in a couple of weeks. But my colleagues, Roxana, Anna Sangster, and also Katrina Bouzanis, will be moderating these terrific sessions. So, Thomas, one thing that you just said to us, which is really poignant for me, and if we can get this message across, we would have raised awareness, and that is that it's not normal to feel lonely. And when you said that, there are a number of people on my screen nodded. And I think what you have shared with us today is a real story. You talked about the political will. You talked about the left and the right and wiping off agendas. And we know that exists, but it's very rare that you hear someone say that. We explored, what intergenerational learning could look like, but it came out of an idea. And it's quite true. We send out ideas, there's either silence or good idea or one or two. And so you've really inspired me to go back and throw out those ideas and wait for the one or two, but recognize that we live in a very complex political world that does impact. But I'm inspired by who you are, what you do, and how you describe, the importance of mental health. So with that being said, I want to thank the IFA staff for always being on these important cafes, Bruna, Luana, Jasmine, and all of my colleagues who are every day inspiring. So Thomas, thank you for being with us. And I know that you had a mad rush with your 3-year-old twins, and we were holding our breath, waiting for you to be with us. But please share with us some takeaway messages, and thank you very much.
No, thank you. It's always a pleasure to be invited to these kind of talks, because you can always keep learning. You're never too much of an expert to not learn from everybody. I think the takeaway message are two. The first one is that mental health, all age mental health, is everybody's responsibility. And for saying that, I'm not saying just like physicians and psychologists, but also the government, the patient themselves, the caregivers. And that is a two-way message. One is that if you think, if I'm a doctor and I think I'm gonna solve everything, I'm terribly wrong. Even if I got the best medication and the best, I won't solve everything. I need help to solve things, and I need help from all the teams that will impact their patients, but also from them, you know, to tell me what they really need, what they really lack. And the second takeaway message is that probably dementia, and that is my field, is an issue in all ages and in all governments and in all like context. Last stories that I want to share is that we have a friend in Nicaragua who want to try to implement the national plan of dementia, and the president told them that, yeah, but we don't have that many old age people because we are a poor country and people die young, and we are taking care of more, if you know, basic issues like water and a roof over the head of the people. And what we have said to them, because we have hired like a consultant, that this is the moment to tackle dementia. You know, this is not now is when you want to tackle dementia, because you don't want dementia to come. And probably if I go to, I don't know, Japan with a very aged society, I will also say this is the moment to tackle dementia. Always is the moment to talk about and to care about dementia.
Look, thank you very much, Dr. Tomás León. It's been a great pleasure. And I hope our paths cross many times again, because I've just, I feel like I've really been sitting over a coffee table, having a cup of coffee with you. So thank you. You know, you're inspiring, very important in the conversation around mental health, and may we meet again. Thank you very much for everybody. Stay safe, stay well, and we'll see you next week. All the best. Bye-bye.